Organiza la Universidad de los Andes con el SINS. En esta ocasión tenemos el honor de tener al doctor Christopher Gibbons, neuromuscular de la Universidad de Harvard, que hablará de neuropatía fibra delgada. La introducción al doctor Gibbons la hará el doctor Nicolás Herr, que fue también becado nuestro de la Universidad de los Andes. Así que los dejo a ustedes con Nicolás y luego con el profesor Gibbons.
Muchas gracias, Jorge. Es un placer tener al doctor Gibbons. El doctor Gibbons, para que se hagan una idea, él estudió medicina en la escuela de Albert Einstein, hizo su residencia en el Johns Hopkins y hizo su fellow en el hospital de Beth Israel, en Boston. Tiene muchas publicaciones en autonómico, en biopsia de piel, en hipotensión ortostática, ha participado en capítulos del Handbook de Neurología Clínica, en el Continuum. Sus publicaciones son excelentes y sugiero que las revisen. Y va a hablar de un tema muy, muy interesante hoy día, que es en particular sobre las biopsias de piel, que creo que son útiles, muy necesarias en nuestro medio. Así que, Dr. Gibbons, thank you very much for joining us.
Thank you very much for having me. Let me share my screen. So thank you. It's my pleasure to present Skin Biopsy, a new horizon in diagnostic testing. So you may have heard a little bit about skin biopsy previously, and my hope is to give you a little bit of information about how this might be useful for you, and then also the future direction that skin biopsy might be taking and how to apply this in your own clinical practice. So just as a brief disclosure, I've worked as a scientific advisor for Lundbeck and for cutaneous neurodiagnostics, and I have received research support from Grifols for an ongoing research study. I thought it would be helpful to present a case to sort of provide some background into what I'm thinking and how this might be useful for you as well. So I'd like to talk about a 64-year-old woman who presented with a 3-year history of progressive but relatively mild numbness and tingling in her legs. The symptoms were mostly bothersome. They weren't painful. She wasn't having any trouble walking, but she was concerned about this. It seemed to be getting worse over time, and she was worried about what was causing this problem. She had seen her general practitioner and some other doctors, but had not been able to receive any diagnosis. They weren't sure what was causing it. One of the doctors had ordered an EMG and a neuroconduction study looking for neuropathy, but that was normal. So when the patient presented to me, she had no past medical history. She was not taking any medications. There were no allergies, no significant family history. Under review of systems, she noted that she would be dizzy or lightheaded when standing. She had some trouble with urination, some trouble with constipation. She also felt that her handwriting had gotten worse over the last year. Interestingly, she noticed that she does not sweat anymore when exercising if it's warm weather. So if I go to her examination, her blood pressure when lying down was 138/78, so a little bit of high blood pressure while supine. But after standing, within 3 minutes, her blood pressure dropped to 106/65, so she did have orthostatic hypotension. But her pulse was 64 supine and 67 standing, so there wasn't much change in her pulse. Overall, her general examination was unremarkable. She was a well-appearing woman. On neurologic examination, her mental status was full. She was fully alert and oriented, could recount a complete medical history. She had normal cranial nerves, full strength, normal reflexes. There was some subtle dysdiadochokinesia of the left arm, but sensory exam was intact to light touch and proprioception. There was some reduced pinprick and temperature in both the feet and the legs. So she had presented with some ancillary data. She already had an EMG and nerve conduction study that as a routine workup for neuropathy was normal. She also had an MRI of the brain because of some of these other features, the dysdiadochokinesia, but that was normal as well. However, we saw orthostatic hypotension on her exam, and there were some features of autonomic dysfunction in her history, so constipation and urinary dysfunction. So the question is, should we think about getting autonomic testing as part of this? We have a question of a neuropathy. So the question is, would skin biopsy evaluation for small fiber neuropathy be of value in this case? So she did go for autonomic testing. And I'll describe briefly what this entails. So the first thing she had was something called a Valsalva maneuver. This is where you're blowing into a tube with resistance to provide a change in blood pressure. So you see here, this is exhaling against resistance to 40 millimeters of mercury. And up here, you're seeing the beat-to-beat change in blood pressure. So as you exhale, blood pressure drops. Normally, with an appropriate intact autonomic nervous system, you would see a recovery here, but it doesn't recover. It just flattens out and then drops and then slowly recovers back to baseline. So this is relatively abnormal. There should be recovery here. This gray line shows you the heart rate response. Normally, when you get a change in blood pressure like that, there's a significant tachycardia that occurs in a recovery. So there's very little heart rate response here as well. So we see evidence of parasympathetic dysfunction here. And then this change in blood pressure without recovery is sympathetic adrenergic dysfunction. So both branches of the autonomic nervous system are affected here. Now this is paced breathing. So these are simple deep breaths in and out. And this is the sinus arrhythmia that you might see on an EKG. Normally, with deep breathing, this may fluctuate by 10 or 20 beats per minute, so significant fluctuation, but this is reduced. So there's reduced parasympathetic function here. And then on tilt table testing, as was seen on stand, when she goes from the supine position to upright, her blood pressure drops significantly, but there's relatively little change in her pulse. So again, we confirm there's both reduced parasympathetic function and sympathetic adrenergic dysfunction as well. She had sweat testing by a device called QSART, which measures the change in humidity in response to a stimulus. And there is reduced sweat production as well. So we're looking at a third branch of the autonomic nervous system, the sympathetic cholinergic system, was damaged as well. And so globally, when you see this type of picture, you suspect somebody with a more significant dysfunction of the whole nervous system, although we don't yet know why. Now, some of you may be familiar with the use of skin biopsy. It has been around now for about 20 years. There have been societies establishing the technology and the technique for doing this. But a skin biopsy is a simple 3-millimeter punch biopsy, and this is what you see. It's just a small hole that does not require any stitches. It's a relatively simple technique and safe to perform in the office. But what we see is over here on the left side of the screen is a light microscope image. And this very top layer here is the epidermis. And this is what we look at when we talk about intraepidermal nerve fibers or small fiber neuropathy. It's the number of nerve fibers seen up in this top layer. But as you can see down here, there's a lot of information to be seen. These are hair follicles, sebaceous glands, sweat glands, piloerector muscles, and blood vessels. And the same thing seen on an immunofluorescent image. So there's a hair follicle down here, and again, sebaceous glands, sweat glands, piloerector muscles. So there's a lot of information below the surface of the epidermis that we don't really talk about. But what you generally see is this layer here. This is the topic of small fiber neuropathy. And these tiny little nerve fibers piercing through this are what are quantified. So a result would tell you yes or no, and the number of nerve fibers in the skin that might determine a neuropathy. But again, we can see a lot of this important information down deeper within the tissue as well. Now, we do know that there are normal databases that have been provided worldwide and by sex, so for women and for men, and by age. So we know what's considered normal and abnormal, and these are the 5th percentile cutoffs. So as you can see, over time, as you get older, you do lose epidermal nerve fibers. And it is slightly different between men and women, so you have to use the appropriate normative value. Now, if you've never performed a skin biopsy before, you may be concerned that, this is not a neurologist's technique, or it's something I'm not familiar with, but it's actually quite easy to perform. So you simply sterilize the skin with alcohol first, and then you provide a local injection of lidocaine, and I prefer lidocaine with epinephrine at 1 to 100,000. And you administer this like you would a tuberculin wheel, a very superficial injection, and you see this raised wheel and blanching because of the epinephrine to make it essentially a bloodless procedure. When you perform a biopsy, you do a simple twisting procedure in order to prevent crushing of the skin and folding of the tissue. And then once you've done that, you simply use a forceps to grab below the epidermis, which you see here, because if you grasp the epidermis, you can actually crush these nerve fibers. And then you cut through the base of the skin right down here, and that's essentially the entire procedure, and you put a Band-Aid on top. So the process itself is quite simple. However, there are questions, when might you order a skin biopsy if it were available? And I like to think of this as I would any other test for a neurologist. If you have a specific question that you need help answering, this might provide that tool. So typically, do you have a neuropathy or not? Or if you have a neuropathy that's due to a known disease and you've now intervened, you're trying to monitor to see if you're making an impact, if nerve fiber density is improving. So this is how you might consider using a skin biopsy. But what does it tell you when you get a report back? So it tells you the density, and this allows you to interpret whether there is a neuropathy or not based on age and sex. But it can also tell you about the type of neuropathy, which might be useful. Is it length dependent or non-length dependent? Because this makes a difference in terms of the differential diagnosis and potentially of the treatment. But there are some errors to think about and cautions with skin biopsies, and I want to highlight this because I often find errors in judgment about clinical diagnoses because of a problem related to a biopsy. So if you pinched the biopsy, you can crush the nerve fibers and reduce them. So the process of the biopsy itself, or if the biopsy is placed on gauze and allowed to dry out for a minute or two, it can actually damage it. Or if it's placed in a freezer and frozen inadvertently before it's processed, or if it's even fixed for too long in the solution, the fixative solution. Or again, even if the lab is not processing it correctly. All of these potential interventions here or problems will cause the nerve fiber density to go down and result in a false positive diagnosis of neuropathy. But if the intraepidermal nerve fiber density is normal, it cannot be an error because you cannot see nerve fibers in the setting of an error. And so it's important to recognize that a normal result should give you confidence there's no neuropathy. But if the biopsy result does not fit at all with the clinical scenario, somebody ordered a biopsy for unclear reasons and it was wildly abnormal, that the exam is totally normal and no history, you do want to be careful about putting too much stock in that misrepresented result. But let's jump back to our case and see if this biopsy might help us. So if you recall, the intraepidermal nerve fiber density at the distal leg, this was for our patient, was 0.9. And for her age and sex, it should be more than 3.2. So this is telling me it's abnormal at the distal leg. But at the distal thigh, it's just below normal. It's 6.5, and it should be more than 6.7. But it's clearly going up. So what this is telling me is there is a length-dependent component because its more proximal site is more normal. So we see this length-dependent neuropathy. And visually what I'm seeing is the epidermis, but I'm not seeing any of those nerve fibers that should be piercing through the skin. There's one little tiny nerve fiber that's faintly seen down here, but really this is not what I would expect to be seeing in a normal person. And if I check a very proximal site, there are plenty of nerve fibers available. But if I think about the differential diagnosis of small fiber neuropathy, it can sometimes be challenging because it's broad. And you think about what might be common. So glucose abnormalities, diabetes, impaired glucose tolerance, impaired fasting glucose, these are incredibly common causes of small fiber neuropathy across the world. So treatment-induced neuropathy, even treatment of high blood sugar can cause a neuropathy. But these are all interesting mechanisms that exist that can cause a small fiber neuropathy. This is probably far and away the most common cause, certainly within the United States. But I think as we develop, as many countries are developing an increased risk of diabetes in the population, this continues to be a problem. Monoclonal gammopathies, of course, are related. Alcohol use, again, you have to screen for this. It can be a cause of small fiber neuropathy. Vitamin deficiencies or vitamin excess can cause a neuropathy as well. Toxins such as heavy metals ingestion can do this. Things like amyloid and sarcoid, of course, need to be considered as well. HIV infection or hepatitis C or Lyme disease are all potential common causes. Drug-induced. So clearly, chemotherapeutic agents are the most common cause of neuropathy that we see, at least in an academic center. And so these can be seen regularly, but again, other less common causes, antibiotics occasionally can do this as well. We don't want to forget leprosy that still exists in a significant number of countries around the world. Thyroid dysfunction, immune-mediated vasculitis, porphyria, genetic, and of course, at the end of the day, we may end up with idiopathic in up to 20 or 30% of cases, which can be frustratingly difficult. But I also want to remind you of the concepts of neurodegeneration. So Parkinson's disease, for example, is associated with a small fiber neuropathy in many cases. So there are different disorders, and so I'd like to help with this differential. Now, let's go back to the differential diagnosis in this specific case, because we know that there is a length-dependent small fiber neuropathy. We've now determined that. We also saw that there was dysautonomia in that left upper extremity. There's orthostatic hypotension, constipation, urinary dysfunction. There was also sweating abnormalities as well. So the question is, what is the differential diagnosis in this particular case? And if we want to run through some laboratory studies, we could run through some of the common causes. Of course, glucose would be at the top of our list, the first thing to check, but it was normal. There was no history of alcohol use. Given her age, we might consider paraneoplastic disorders or other autoimmune conditions, but these were normal. We might think about heavy metals, vitamin deficiencies or excess, so we might want to screen for these, but again, these are relatively rare. And the most common heavy metal abnormality is usually a problem where it's a spurious test result related to eating fish within the last few days. And so again, there are limitations to these tests, but infectious etiologies or other immune conditions, sarcoid. But if we look at all of this, those are things we might want to consider, but in this case, let's assume these are all normal, and we may not necessarily have to go through this entire list in the workup. Because one of the things we're suspicious about based on her exam is what about the possibility of Parkinson's disease? It's not a typical presentation of small fiber neuropathy, but we've now detected several features, in particular the dysautonomia of the left upper extremity in the setting of autonomic dysfunction. This moves it into a different category. It's not just a small fiber neuropathy. This is more a global dysfunction of the nervous system. And so neurodegenerative diseases need to be considered. But of course, if we think about this, how might we possibly make a diagnosis of Parkinson's disease? This individual already had imaging of the brain that was normal. So we don't know that there's any, what else might we do to confirm our diagnosis other than to watch over time and see if she develops Parkinson's-like features as time goes on. So this can be a challenging question. But we've now had some really significant new developments in the realm of skin biopsy. So we do know that a lot of neurodegenerative disorders are based on the concept of a misfolded protein. And in particular, the synucleinopathies, which include Parkinson's disease, multiple system atrophy, dementia with Lewy bodies, pure autonomic failure, and even idiopathic REM sleep behavioral disorder, are all characterized by the deposition of phosphorylated alpha-synuclein. And pathologically at autopsy, we know that is how we make the diagnosis. But clinically, that's much more difficult to do, particularly early in the disease course. So is the concept, can we move ahead and perhaps make progress in developing new techniques? And that's what we've been really interested in studying for a number of years now. So going back, this actually publication is now from 2013. And what you can see on the left-hand side of the screen are autonomic structures. So these are piloerector muscles. These are the muscles with the nerves in them that cause goosebumps in your skin. That are attached to hair follicles. Now, these are sweat glands. And again, these are the things we see in the skin biopsy. Now, in green, this is stained by protein gene product 9.5, which is a marker of all axons in the skin. But over here in red, we're seeing alpha-synuclein. And what you can see is in the patients with Parkinson's disease, we see alpha-synuclein within these nerve fibers that we don't see in the control subjects. And back in 2013, this was our first effort in exploring the possibility of detecting other proteins within nerve fibers. We've now moved ahead a number of years, and we're able to detect proteins, in particular pathologic proteins, within skin biopsies. Now, these are the exact same skin biopsies we can use for detection of small fiber neuropathy, but we're adding additional stains on top of the prior technique. So what we look at is here is what we can see today in a skin biopsy. This is a nerve bundle seen within the dermal structure of the skin. And this is in green, a nerve fiber or nerve bundle stained by protein gene product 9.5. But what you can see up here is phosphorylated alpha-synuclein. So in this case, you can see it co-localizing within the nerve bundle. Now, the interesting feature of this, if you're studying movement disorders and synucleinopathies, the alpha-synuclein itself tracks down the single nerve fiber. It doesn't cross into adjacent nerve fibers. So if we think about how proteins spread longitudinally down fibers, we're seeing that visibly here and here. Now, this is our patient with a suspected neurodegenerative disorder, and now that we can see phosphorylated alpha-synuclein in her biopsy, we can confirm the diagnosis of synucleinopathy in addition to small fiber neuropathy. So this gives us a new tool to make a new diagnosis using the same technique. So it's a really interesting advance. So one of the questions we have is, what type of data supports this approach? So this was a set of data we were recently going to present at the American Academy of Neurology meeting, but as many of you are aware, due to the pandemic of COVID, our meeting was canceled as of, unfortunately, most every meeting. But this was data we presented digitally. And what we looked at was the detection of phosphorylated alpha-synuclein across a number of different disease states. We looked at Parkinson's disease, multiple system atrophy. We looked at dementia with Lewy bodies, pure autonomic failure. We looked at healthy individuals and, of course, individuals with a variety of non-synucleinopathy diseases. You can see the gender distribution here and the age of the individuals. The Hoehn-Yahr scores were relatively similar between the Parkinsonian-like conditions. MSA was, of course, more severely affected. And the Hoehn-Yahr score is just that simple metric of a rough estimate of severity of disease, where 0 is no disease and 4 is essentially wheelchair bound. So these are individuals with moderate disease. Cognitive testing through the MoCA score. But what you see over here on the results are the positive tests and then the percentage of positive tests. So as you can see, in Parkinson's disease, we were able to detect phosphorylated alpha-synuclein 97% of the time. But in 100% of time in multiple system atrophy, dementia with Lewy bodies, and pure autonomic failure. We did not detect it at all in individuals who are healthy, and we did not detect this in any other disease states that we investigated. And we've continued to perform additional disease investigations, but this abnormal protein seems selective to synucleinopathy. So what we can determine is that with these normal results here, we have a very high specificity for testing. So at this point, it's approaching 100%. And sensitivity, of course, is now approaching, over 95%. So again, in terms of the utility of this test, it really helps us to make a diagnosis more specifically and potentially in a different way than we're ever used to thinking about the central synucleinopathies like Parkinson's disease, where we think about the substantia nigra as the cause of the problem, even though we know now that non-motor manifestations and autonomic disorders are clearly a significant cause of problems in most of these patients. Now, generally, for the use of phosphorylated alpha-synuclein, we do biopsies in very much the same locations that you would for small fiber neuropathy. We do it down at the leg, down by just above the ankle. We do it laterally above the knee. And then we also do a posterior cervical site, just about 2 centimeters lateral to C7. The reason we do 3 skin biopsies is because, very much like an EEG for seizures, a single one may only give you 74% sensitivity. A second one may move you up to about 90%, but the third one pushes us up to that 98% sensitivity. So generally, we recommend 3 biopsies in total in order to use this as a tool for diagnosis. Now, one of the questions we struggle with as neurologists, and those of us who've been working on this, well, what does this information tell us? So I have a diagnosis of a synucleinopathy, but I don't have treatments for synucleinopathy. So what does that matter? How does this help me if I'm thinking clinically about my patient? Well, if I have a patient with tremor, I may struggle in a small proportion of these cases. The essential tremor case that's obvious does not require any special investigation. The drug-induced tremor that's obvious does not require any special investigation. However, there are always those few cases that we struggle with clinically to determine, is this Parkinson's disease or MSA, or is this some form of tremor that we're struggling with here? Or if a patient has a drug-induced tremor we're suspicious of, but we cannot take that drug away, and we're worried about the development of a synucleinopathy. This is how a biopsy might be able to distinguish clinically between these groups. Similarly, if we have patients with dementia that are presenting, and again, if it's a true classic Alzheimer's type dementia, we have no questions, and we may see the findings on imaging. Or if we have a true classic dementia with Lewy body picture, we really don't have a need for additional help with diagnosis. But we all know that those cases that are early or unusual with different features that we may struggle with. And the misdiagnosis rate at autopsy is typically about 30% between DLB and Alzheimer's. So we know this continues to be a problem even in the best of hands. So this is where the diagnosis might be useful. And particularly if we think about DLB, we obviously would select different medications, particularly if there are behavioral abnormalities that we're worried about. You clearly want to avoid antipsychotics in patients with DLB because of the risk for profound worsening of disease. So this might be a judgmental assistance. Now, dysautonomia, of course, is one of the areas I'm most interested in because all of the synucleinopathies, of course, can cause dysautonomia, but there are a host of other conditions as well. I see a large group of patients with diabetes and diabetic neuropathy. I run the Diabetic Neuropathy Center at Joslin Diabetes Center in Boston as well. And many patients with diabetes will have very stable control for years, but of course, over time, as they get older, they are still at risk for neurodegenerative diseases as well. And so if I have a patient with chronic diabetes that's quite stable, but suddenly they're developing autonomic dysfunction in addition, now I struggle with the diagnosis. Is this diabetes? Do I need to improve their glucose control? Or is this due to a different disease state entirely? And this is where a biopsy can help me distinguish between a diabetic autonomic neuropathy that's probably non-existent or the new development of a synucleinopathy in a patient with diabetes. Similarly, you may struggle with patients who have MSA and you're trying to determine, is this progressive supranuclear palsy or MSA? And which, if they're having falls frequently, which of the diagnoses is this? And the test can help you distinguish between these different disorders. And finally, in a patient with rigidity or bradykinesia, again, you may be worried about corticobasal degeneration or PSP, or you may worry about MSA or one of the other Parkinsonian syndromes, and this can help you distinguish. So these are sometimes very challenging disorders to see clinically and distinguish between, but the vast majority of cases, clinically we can make our own judgments and be very clear. But at least now there are tools in development that might allow clinical judgment to be supplemented with additional testing to help make our jobs a little bit easier, particularly as we talk to patients and tell them what to expect or what to anticipate in the years to come, because the difference in these diagnoses is quite critical. And what do we know about these disorders? Well, certainly synucleinopathies develop with some fairly characteristic diseases that underlie. So for example, REM sleep behavioral disorder, we know over 15 years, patients will develop the accumulation of phosphorylated alpha-synuclein and develop a clinically apparent synucleinopathy within 15 years, 100% of patients. So this is something we know to be in the list of conditions that we worry about. And skin biopsies here, we can actually detect 70% of patients have phosphorylated alpha-synuclein very early in the disease course. So we know we can make this diagnosis now years before a diagnosis of Parkinson's disease could be made. So right now, this doesn't necessarily make a huge difference in the disease course, but ultimately, as we move into a new era with drug treatment where we can modify synuclein deposition, this is going to be absolutely critical to help intervene, because if we can slow the progression of disease early, we have a much better chance of improving our patients' lives. Similarly, pure autonomic failure typically progresses over 25 years into something else, whether it's Parkinson's disease or multiple system atrophy, but we know there's a high rate of progression over a long period of time. And we've been investigating early diagnosis, and we think we can actually make a diagnosis up to 20 years earlier using skin biopsy in these patients. Because we've been detecting it in people in their 20s with early symptoms of pure autonomic failure. So we suspect this is a really interesting avenue that will be hopefully moving ahead in the future, and we'll be able to intervene. So in conclusion, I wanted to highlight how skin biopsy, we already know it's a well-established tool for the diagnosis of small fiber neuropathy. But again, it's not something that's universally accepted or universally used. But it is an interesting tool to help with the diagnosis. But now we're making major advances into what we can do with that skin. And that same skin biopsy now allows us to detect the presence of phosphorylated alpha-synuclein within nerve fibers. And so we can imagine being able to make a diagnosis of neuropathy or Parkinson's disease much earlier in the disease course. And ultimately, because many of the neurodegenerative disorders are due to protein misfolding, there may be a whole host of diseases in the future that we could detect early and really make a significant change in our patients' lives as we develop new therapies. And so again, as we move on to this advantage of early and accurate diagnosis, I think we're going to see this, this arena of the neurologist making a diagnosis but not being able to do anything change dramatically. And we're going to see a new revolution in what neurologists can do in the future. So I think it's a very exciting place that we're moving into. So I want to thank you for your attention, and of course acknowledge many people who've been involved in the work and development of this. And it's, of course, a lot of work still to be done, but I'm happy to talk with you and answer any questions that might arise.
Thank you, Dr. Gibbons, for your fascinating talk. Les quiero comentar que por favor contesten la encuesta. Esto toma un par de minutos. Es súper importante para nosotros tener el feedback de toda la audiencia. Por favor, hagan las preguntas en el icono de preguntas y respuestas. Y voy a partir contándoles una pequeña experiencia. I'm just going to tell the audience just a brief experience with skin biopsy I had. Un par de años atrás tuvimos el placer de tener al doctor Todd Levine, que también tiene mucha experiencia en neuropatía de fibra delgada, y vimos una paciente en la clínica que nos estaba ayudando con el diagnóstico, una paciente con un cuadro de dolor neuropático muy severo, con algunos síntomas autonómicos, y que por años, una paciente joven de 28 años, que por años había tenido un diagnóstico entre Sjögren, un lupus, nunca se había establecido, los anticuerpos a veces salían positivos, negativos, había un diagnóstico posible de funcionalidad, y se le hizo la biopsia en el muslo y en la pierna, y no solamente confirmó la teoría que tenía una neuropatía de fibra delgada, sino que además estableció que no era longitud dependiente, lo cual reforzaba el diagnóstico de un cuadro inmunológico. Y fue muy refractario el tratamiento y finalmente decidimos con la paciente que lo mejor era inmunosuprimirla con azathioprina, una mujer joven. Fue una tremenda decisión con una mejoría notable. Así que esta técnica ojalá la podamos introducir en nuestro medio. Han habido esfuerzos en la Universidad Católica, en el Hospital Clínico de Chile. Probablemente algunos de los que están en la audiencia también tienen experiencia, pero requiere de que tengamos una conciencia colectiva y empecemos también a exigir. Y hay varios problemas técnicos y económicos de establecerlo en nuestro medio. Voy con las preguntas ahora. La primera pregunta es del doctor Mario Campero. Mario Campero pregunta, so the first question is, if you would prefer a skin biopsy with intraepidermal nerve fiber density or quantitative thermal sensory testing for the diagnosis of small fiber neuropathy?
So I think both of those tests can be useful. And in part, the simple answer is, what do you have available? So if you have one or the other, that allows you, I think different options, of course. But quantitative sensory testing has some advantages, which is it's a functional test. So it tells you what the patient is really perceiving. But on the same side, it's also limited by their response. So a patient who's drowsy or on medications will not respond in the same way. And the quantitative sensory testing is usually abnormal in patients with any sort of cognitive impairment or who are struggling with answering the questions appropriately. So there is a limit because you give a stimulus and you have to get the response. Skin biopsy is more pathological. So it's providing you a confirmation pathologically of what you're evaluating. So I think the skin biopsy can often provide more of a confirmation of neuropathy. Quantitative sensory testing can help support your diagnosis of that. But essentially, your examination is often a quantitative sensory test. So pinprick, for example, or if you take a vial, I often use a blood tube and fill it with hot and cold water. And I can then have thermal temperature detection, hot and cold. So I can use a bedside quantitative sensory testing. And that's usually, to confirm a diagnosis, very helpful. If it's usually the more difficult cases, the non-link dependent neuropathies, or the patient with a severe small fiber ganglionopathy, where all the nerve fibers are affected throughout the body. Those are very difficult to determine because then there's no difference in the sensory testing distally and proximally. So you don't really get an idea of what the problem is. And that's where skin biopsy has an advantage. But both can be very useful.
Thank you very much. La segunda pregunta es del doctor Carlos Navarrete. So Carlos Navarrete asks with the data on the alpha-synuclein studies you've done, do you think the noxious, the starting point of these diseases will start in the peripheral nervous system and travel to the central nervous system? What do you think?
It's a great question. And I think the challenge we have, of course, is if you think about the Brock hypothesis of synuclein spread, it starts perhaps in the gut and then spreads, or potentially through the olfactory bulb and spreads distally. That would imply that the last thing to be involved would be the peripheral nervous system. However, we're seeing this very early. So it's probably a more complicated process where somehow it's getting in, whether it's in the skin and going proximally or getting in the central nervous system and spread distally. I'm not sure we know that yet. And I think this is something we're going to continue to have to investigate, because it's a really curious problem that when we look on these biopsies, we see it travel down the nerve. So we know it's going proximally and distally, but we don't know which direction it's traveling. And so it's a curious problem, and I would love to give you a better answer, but I don't have one yet.
Thank you very much. I have a question. How important do you think it is to differentiate between a non-length dependent and a length dependent small fiber neuropathy in respects to differential diagnosis and treatment?
I think that actually it's a great question. I think that can be very important. So for example, a non-link dependent neuropathy is really unique. And actually, maybe I will just jump back quickly to a couple of slides, because this list, of course, is very different if I'm thinking about non-link dependent neuropathies. So if I'm imagining any of the glucose control abnormalities, diabetes, impaired glucose tolerance, or impaired fasting glucose, those would be moved off the differential diagnosis. Treatment-induced neuropathy can cause a non-link dependent neuropathy. The vitamin deficiencies are usually link dependent. You can get with B6 ingestion, with massive quantities of B6 ingestion, you can get a ganglionopathy type picture. So that could be, again, on the differential. Heavy metals, so thallium, for example, in a high dose could cause this. Sarcoid actually would be much, much higher on the differential diagnosis. In fact, sarcoid would probably be at the top or near the top as the cause of non-link dependent neuropathies. Similarly, Sjogren's syndrome would jump up to the top as well, or potentially a paraneoplastic syndrome. But the rest of these, of course, would then disappear almost completely off the list once we separate link dependent and non-link dependent. So I do think it would be very helpful to just separate these two.
Great. Dr. Gibbons, would you stop sharing screen?
Oh,
so
sure.
Thank you.
There we go.
Okay. The next question is from Dr. Ricardo Hughes. He asks about the importance of making a skin biopsy in a patient with fibromyalgia, and what meaning that would have of an abnormal biopsy.
So that is a difficult question, and I'm not sure we know the answer yet. As you're aware, there are a number of publications which suggest that patients with fibromyalgia may have a small fiber neuropathy. I have not seen that data, convincingly reproduced yet. So I think some patients may have a small fiber neuropathy. Most patients do not. So I'm not sure yet what that information is telling me. Now, if I detect a small fiber neuropathy on examination, that's a different story. Maybe that's a small fiber neuropathy misdiagnosed as fibromyalgia. And then maybe I can treat the underlying condition for a small fiber neuropathy. So if my exam is consistent with a neuropathy, and I want to perform a biopsy to confirm this, that might be helpful. But I think in the average patient with fibromyalgia, I'm not sure that helps me at all.
Okay. Dr. Juan Carlos Casar, he asks about if synuclein staining in a biopsy seems to be very sensitive in MSA, multiple system atrophy, but autonomic dysfunction in this condition is considered to be predominantly central or preganglionic. Could you comment on this difference?
Yes, and it's a really curious problem. So we do see, of course, that in the central nervous system, the alpha-synuclein there is within glial cells. It's within the supporting structures, not the Lewy bodies, which we see in Parkinson's disease and dementia with Lewy bodies. So there seems to be a different disease between these two. Peripherally, of course, we don't have any glial cells, but somehow we still detect the deposition of alpha-synuclein there. Now, we have seen some interesting data that suggests that MSA, the deposition is much less than in Parkinson's disease or dementia with Lewy bodies in the peripheral system. So there may be something to this, but we don't know for sure. So clearly MSA is a much more rapidly progressive disease. And one of the things we notice that's different between these disorders is that MSA does not have a peripheral autonomic neuropathy. So in other words, they don't lose those nerve fibers. Whereas in Parkinson's disease and dementia with Lewy bodies, they actually get peripheral denervation. You can see that on cardiac neuroimaging, but also on the biopsy. We see the sweat glands, the density is reduced. the piloerector muscles, the density is reduced. And so in MSA, that doesn't seem to be the case. So it may be that we're picking up synuclein in this disorder, but it isn't causing the same pathological problem where it really is a central synucleinopathy in MSA. And that's a great question.
Very interesting. Dr. Mario Campero asks if phosphorylated synuclein is expressed in non-myelinated fibers only, or they are also expressed in large fibers in the peripheral nervous system.
So it's predominantly in either unmyelinated or lightly myelinated fibers. So the autonomic fibers, of course, carry some light myelination. And so there are fibers that do have that. Most of the large nerve fibers, so for example, muscle fibers, things like that, will not carry any sort of synuclein. But generally, we don't see them as well, of course, on a skin biopsy. And so we're getting only the very superficial fibers. There are some reports where myelinated fibers are more affected in multiple system atrophy than in the others, but this has not yet been confirmed. So I think that's a question we're continuing to investigate, but we're looking to see if there's a difference.
Okay, thank you. Juan Francisco Illaques asked if the QSAR test, Pseudomotor test, in small fiber neuropathy, what would be your experience with this technique?
So the QSART can be very helpful. It can detect a very early small fiber neuropathy. So potentially, one of the challenges with skin biopsies that you think about is if you start with 50 nerve fibers, but our threshold for abnormality is 5, there has to be this period where you're losing nerve fibers before you hit this threshold. And of course, there may be a period of pathology that's occurring that we can't detect until they hit this threshold on a biopsy. However, with QSART testing or pseudomotor function testing, you may pick up some early abnormalities that are changing during that time frame. And that may actually be earlier even than skin biopsy. However, the difficulty with sometimes that diagnosis is that there are many medications that can cause changes in sweat production. So of course, any of the anticholinergic medications or any sort of antidepressants that have those effects can change sweat production and cause problems. So it's a more sensitive test, but at the same time, that results in less specificity. So sometimes that can be a challenge, but I do find it a useful test, particularly if there's any question about anhidrosis involvement or things like that, where sweat may in fact be impaired.
Okay, thank you. Teresita Ramos, she thanks you very much for your wonderful talk, and she asks if you have seen small fiber neuropathy in other central nervous system degenerative pathologies in addition to those related to alpha-synuclein.
So, so that's a more difficult question to answer, and I think we do see it in some cases of neurodegeneration. And I think there are reports in the literature of different disorders. We see it specifically more frequently in Parkinson's disease than compared to MSA. MSA sometimes has it, but not as frequently. And so that is one differential, but that's of course all within the synucleinopathies. You can, of course, see in any of the age-related neurodegenerative disorders some decline in nerve density, but typically patients with Alzheimer's disease, for example, won't necessarily have a small fiber neuropathy, but patients with ALS will actually. So patients with ALS will typically have some degree of small fiber neuropathy that may not necessarily even be in the limb that's affected. So there's some question about an overall neurodegenerative process damaging the health of the nervous system. So I think those are tough questions because there are a number of diseases we still need to investigate that we're not sure of.
Thank you. Someone asks if what treatments can we give the patients with sensory positive sensory symptoms, small fiber neuropathy, pain related? Just a brief answer to that.
Yeah, so the treatment of small fiber discomfort, it can be very, very rewarding because you can make a big difference. So a lot of that will depend on the age of the patient and their risk factors. So if they're a younger person, not on many medications or don't have risk factors, some of the best treatments are tricyclic antidepressants. They're older, but they're very effective. But if the patient is older than 65, they're contraindicated because of risks of confusion or mental status changes. But those are very good early on. Things like gabapentin or pregabalin, of course, can be useful, but can be more expensive and may be drowsy, cause drowsiness, as the tricyclic antidepressants can as well. But for patients who have symptoms typically at night where it's more prominent, you can dose gabapentin only in the evening or at bedtime and not give it during the day, which is a nice approach to help reduce side effects during the daytime. Of course, the SNRIs are helpful. The serotonin norepinephrine reuptake inhibitors, such as duloxetine or venlafaxine, can be very helpful. They're not as effective as the tricyclic antidepressants, but they have fewer side effects. So those are good options as well. Topical things, if you have a patient with just distal symptoms in the toes, topical treatments can be helpful. So topical lidocaine just to help them get to sleep. A trick is actually to use topical lidocaine with a saran wrap, a plastic wrap around it, so it's not dispersed onto the sheets and lost off the skin. So that can sometimes be a solution. Capsaicin cream, of course, has been used for many people for many years. It hurts, particularly the first few times that you apply it, and you have to be careful not to get it on your hands and then to touch your eyes because you could damage your cornea. So those are all treatment options that can be helpful. I do not like opioids. Clearly there's a danger with that, so I would be very cautious about those.
Okay, thank you. I think we have time for one or two more questions. Maria Eugenia Jerez asks, what do you think is the effectiveness of duloxetine?
So duloxetine has what's called a number needed to treat value. All of these drugs have what's called a number needed to treat value. And the way to think about that is how many patients do you need to treat before one patient improves by 50%? So if I treat 5 patients and 1 gets better, my number needed to treat is 5. Duloxetine actually is 5. So that means really it takes 5 patients before 1 gets 50% better. In contrast, the number needed to treat for amitriptyline, a tricyclic, is 2.3. So it's much lower. Gabapentin is about 3.4. So it's sort of a little bit, not quite as good as amitriptyline, but much better than duloxetine. But say the SSRIs like Paxil or things like that, which we don't think of using, those are about 12 or 15. So again, not useful medications. So maybe that helps to give you some idea of the relative efficacy of that.
Okay, I have another question. Do you think we should implement skin biopsies in Chile? And what are the main challenges to implement in the neurological practice?
So, I think anytime you're introducing a new test, it's important to sort of understand with your groups of neurologists that are there, is this something they find useful? If they find it of value theoretically, that's the first step in the introduction. Now, clearly this is a technically challenging test to perform, but it is accomplished, and there are many labs now around the world who are starting to do this. So it can be done, and certainly with some additional training and support from colleagues that are already doing this, it makes it easier. But I think the first step is understanding how it can be done, and that's where neuropathy centers often would take the lead for individuals who treat the most patients. Once they find it useful, others may begin to see how that can be applied in their own practice.
Okay, well, if there are no other questions, I would like to thank you in the name of all the audience and Universidad de los Andes. It's been a great talk. Thank you for giving us your time.
Thank you very much. It was a pleasure to see all of you briefly by Zoom, and hopefully we'll have a chance to meet in person one of these days.
Oh, we hope to. Y por favor, llenen la encuesta. Les pedimos que su opinión es muy importante para nosotros. Doctor Villacura.
Thank you very much, Professor Gibbons. Gracias Gracias, Nicolás. Y también, bueno, gracias a la audiencia. Sabemos que jueves, eso es miércoles hasta ahora, estamos todos cansados. La charla ha sido muy buena y esperamos tenerle en los siguientes webinars que tenemos. La próxima semana de depresión secundaria, el accidente cerebrovascular, de infarto, en otra de distonía, y después en octubre ya viene el SINS. Así que muchas gracias a todos y les esperamos la otra semana. Muchas gracias. Chao.
Ciao. Thank you very much.
Yeah.
Bye bye.
Bye-bye.